We are going to start a very important disease. All of you, I believe, by this time know what is the urinary system. Urinary system, mainly of importance, is kidney, ureter, bladder in male, prostate, and urethra. These are the parts which comprises the urinary system. And the urinary stone disease is the disease which affects mainly 3 to 7% population mainly in the industrial area. 3 to 7% population in the industrial area by their lifetime get renal stone disease. And the history is, if a person is a stone former, he is always a stone former. The reason is there must be some predisposing factor which leads to the formation of the stone, and if this cannot be changed due to some inherent cause in the system or in the environment, he is bound to recur with the stone disease. And what is the incidence of it? The incidence is, once a stone former, he will develop the second stone. The chance of developing second stone is nearly 30% over the year of 7 years. By the 7 years time from the first incidence of the stone disease, there is chance of recurrence. And it is found that male population is affected much more than the female. The ratio is around 3:1. 3:1 population, male and female, is the distribution of the stone disease. So, what is important in the stone disease? Stone disease is a very painful situation if it presents as an acute condition, and if it presents as a silent situation, it is going to destroy the kidney. So in both way, it is of great importance. If you don't take care of the patient, either the patient will lose the kidney or there will be acute pain in the system. Without going into much detail, I just show you what are the types of the stones which forms in the system. First of all, why should the stone forms in the system? Why it is not forming in the gut? Why it is not forming in the intestine? Why it is in the kidney? Why the urinary system is prone to develop stone? Because urine contains lots of solutes, out of which there are many ionic substances. These ionic substances, if they get saturated, I will tell you what is the pathophysiology of developing stone, and they actually precipitate in the system, mainly in the distal tubule, and gradually it is expelled into the collecting system. You know what is distal tubule, what is collecting system. I am not going through the details of it. The distal tubule, then it is projected inside the collecting system to produce the initial stone formation. So what are the types of the stones normally find in the system? First is the calcium oxalate, calcium phosphate, struvite or the magnesium ammonium phosphate, cystine stone, uric acid stone, and specially I have mentioned one stone, that is Indian stone, which is not very common, but this kind of stone is associated with mainly HIV affected patients who are treated with this particular medicine. HIV affected patients, those who are treated by this medicine, are prone to develop this kind of the stone. What is the specialty of this stone? In the normal X-ray, ultrasonography, and also in the CT stone, it is not detectable. It is only on clinical presentation you will have to assume that the patient is having a stone disease, and you will have to treat the patient accordingly. So even the CT scan cannot pick up this stone. That is the importance of this Indian stone. That is why I have kept in the list. Calcium oxalate stone and calcium phosphate stone, these are the most common stone and comprises nearly 65 to 70% of the total stone disorder. Magnesium ammonium phosphate, the struvite stone, these are usually infective stone. Infection in the system precipitate in this stone formation. And cystine stone is a metabolic disorder. If there is cystinuria in the body, Normally, we are not expelling much amount of cystine with our urine, but in few of the population where there is some metabolic disorder, they excrete more amount of cystine in the urine, and they are prone to develop this cystine stone. These are basically radiolucent stone. So you will have to be very careful in this kind of a patient to detect the stone disease. Normal X-ray KOB will not be able to identify this stone disease. Uric acid stone is another metabolic disorder. If there is hyperuricemia, that means in a gout patient you have seen, number of times you have seen that the patients are coming in the outdoor. You will gradually, when you will go to the OPD, you will see in the clinics that the patients are coming with joint pains, and if you screen or if you take history from this patient, you will find there is a history of stone disorder, stone disease, and these are the uric acid stone. They should be taken care of. So these are the types of the stones normally found. Most common calcium oxalate and calcium phosphate. Next common is definitely uric acid stone, then struvite stone, uric acid, cystine stone, and Indinavi stone is a very rare disease. The importance of lies because it is associated with HIV affected patients, those who are treated with this medicine, Indinavi medicine. There is a balance, there is a balance. Why everybody is not forming stone? Because there are some precipitator, and there are some inhibitors. What are the precipitators? There may be congenital deformity in the form of renal tubular acidosis. There may be cystinuria. There may be medullary sponge kidney. These are the congenital conditions that predisposes the patient to develop stone disease, more excretion of the calcium in the urinary system. Another important cause is the hyperparathyroidism, which may be associated with this stone formation. That I will come later. Second cause is the dietary habit. The having junk food is one of the very important factor in developing the stone disease. Main reason is the more sodium content into the food. So presence of sodium in the system allows more excretion of calcium in the urinary system. So sodium content is a very important factor. Junk food is very, very related to it. Third is the climate, very hot climate, and there is frequent dehydration in the system. We produce concentrated urine. In concentrated urine, there is more solutes with ionic solutes, which are the predisposer for the stone formation. And fourth is the sedentary nature. Sedentary nature also allows, you will see the stone disease is more common in the industrial belt, industrially developed countries, but not so much in the rural background where people work hard, they work in the field. So the incidence of the stone disease is more affecting the civilized society of our country, all over the world. You more civilize the country, the more incidence of the stone disease related to it. As these are the predisposer of the stone formation, there are certain inhibitors. Which prevents stone formation. Number one is citrate. Number one is urinary citrate is the major factor which prevents the formation of the crystal. Which prevents the formation of the crystal is urinary citrate. These allows 50% chance in a case patient we have studied, those who are having recurrent stone disease. If we try to find out urinary citrate, we always find there is less amount of citrate in the urine. The absence of a less amount of citrate is one of the very, very important factor, which is not a preventer of the urinary stone disease. Apart from which, there are many other factors. I am not going to the details. Stem hotspot protein and many other substances, ammonium, magnesium. These are also helps in the prevention of the stone disease. But remember, citrate, which is the most important factor in preventing the stone disease. And now there are ways how the stones are formed. There are basically two very simple proposition. All of you have seen that if you pour lot of salts in a glass of water, what will happen? You go on pouring, and after some time you will see some amount of salts are getting precipitated at the bottom. So whenever there is abundance of the ionic substances in the urine, how it happens? It may happen due to overproduction. It may happen due to concentration of the urine. That means you are dehydrated. Or it may happen if there is some amount of obstruction somewhere by which the excretion of the products are not possible. So either it is overproduction or it is concentration of the urine. Third is the obstruction, which allows precipitation of this or the presence of superabundance of the ionic contents in the form of calcium oxalate in the system. And how it is formed? That first it is formation of the aggregation. There is aggregation of the solutes. They aggregate. Then they form nucleization. There is nucleization of the stone particles. How it happens? Normally on a portion of the epithelial cells from the system. Some of the epithelial remnant or some of the denuded epithelium may act as the initial nidus on which these aggregated particles, they coalesce and form aggregated nucleization of the stone. After the stone nucleus is formed, on which gradually stones, different chemical ionic substances start getting deposited and the stone formation take place. This I have said, and how this has been supported by matrix. There are certain mucoprotein which are present in the urine which has a dual role. Dual role in the sense those who are not stone former, they prevent stone formation, this matrix, mucoproteins. But those who are stone formers, they help by providing a scaffold on which this nucleus or the ionic particles, they get deposited to form the stone. Understand what did I say? Matrix is a mucoprotein which normally helps in the formation of the stone. But surprisingly, those who are not the stone former, in that case, it helps in prevention of the stone formation also. Exact mechanism is not known, but it is found that matrix has a dual role. Third is epitaxy. What is epitaxy? Epitaxy is formation of a stone of different constituents layer by layer with similar structure. Like calcium, suppose you have got a calcium oxalate stone on chemical analysis following removal. On cut section, you will find there is a uric acid nidus inside. There is a uric acid stone inside on which the layer by layer the calcium oxalate stones are formed. This is how, these are the basic mechanism, as I have said, the precipitation, matrix and epitaxy, and it is formation is prevented by absence of inhibitors in the stone formation. If the citrate and other substances are absent, these help in the formation of the stone. Remember this because this is a commonly asked theory short notes. It's a commonly asked theory short notes. That's why I'm giving importance for you to understand. Even if you don't read, you can write it down, because if you understand the pathophysiology of this stone formation. Look, what I have said already, it is the matrix provides the scaffold for stone formation. Precipitation crystallization refers to the supersaturation of the urine with specific ions composing the crystal. Supersaturation leads to nucleation, crystal growth, aggregation, increased likelihood of stone formation. Whatever I have said is very clearly mentioned. Epitaxy is the aggregation of the crystal of different composition but similar lattice structure leading to formation of stone of heterogeneous nature. As I have said, you have got a calcium oxalate stone, but you cut off, you will see the uric acid stone inside. And fourth is the inhibitor like the citrate, magnesium, glycosamine, different glycosamine. You don't have to remember so much. Remember citrate and magnesium, because in commercial preparation you will see portrait MB6. Portrait MB6. These are the commercial preparation they make with this. This composition they make, which are the preventers for the stone formation. Now, how they will come to you? You know the theory, the stone formation. How do they come to you? Many of them are asymptomatic. I have said at the beginning, what is the importance of asymptomatic stone? Asymptomatic stones may be detected incidentally. Suppose he has come for, or he has been evaluated for some other disease, we find there is a stone in the kidney. These are the asymptomatic stone. But what is this importance? Importance is, if we miss a asymptomatic stone, this may stay in the system, and this may cause obstruction. Slowly they will increase in its size, and they will cause obstruction, and they will destroy the parenchyma, because there is increased pressure inside the system, which leads to the dilatation of the system and increased pressure inside the system. These asymptomatic stones are mostly magnesium phosphate stone. Struvite stones, they normally do not come as an acute pain. So we normally treat the patient for urinary tract infection, because it is very commonly associated with urinary tract infection. If you don't assess the patient in totality thoroughly, so remember, whenever a patient comes with recurrent urinary tract infection, always evaluate the patient's total urinary system to rule out any other associated problem related to it. Either it is stone disease, or it is infection, sorry, or it is obstruction in the urinary tract somewhere. So these are the things must be evaluated when a patient comes to you with recurrent urinary tract infection. The second is flank pain, which is the most common presentation we get. That I am talking about ureteric and the kidney stone both. What is flank? What is flank? What do you understand by flank pain? If you look at the structure like this is the area. This is the area in your body. So starts from here to this part. This is the area, is the flank. They come with flank pain. Why? Why they come with flank pain? The reason is, always try to remember by reasoning. Why do they come with this flank pain? Because the kidney, ureter, these are the retroperitoneal structure. Kidney, ureter আর retroperitoneal structure. এই ক্লাসে এরকম ভাবে ওপেনলি হাই তুলো না, বুঝেছো? তোমাকে বলছি এরকম ভাবে হাই তুলো না ক্লাসে। তো kidney ureters are the retroperitoneal structure. So retroperitoneal structure's presentation is usually through the flank. Whenever the stone comes down to lower ureter or in the bladder, the nature of the pain changes. When it is in the kidney, suppose Stone is in the kidney, the pain will start from here and it will radiate. It will radiate in the lower abdomen. It can, in male, it can go up to the testis. It can even go at the tip of the penis. This amount of radiation takes place in a case of the urinary tract pain. Stone disease related pains are usually referred pain along with acute pain. The nature of the pain will be spasmodic. Spasmodic pain, it will come as a spasm and it may radiate from back to the lower abdomen, in case of male up to the testis or into the tip of the penis. So remember, this is the nature of the pain which takes place in case of the renal stone disease. Third is incidental finding of microscopic hematuria or gross hematuria. It can also come as gross hematuria, though the incidence of the hematuria is much less in relation to the urinary cancer disease, urinary neoplastic disease, but still this is the presentation, especially if it is a lower calyceal stone which is not detected, is lying down for a long time. It may come as a hematuria as a presentation in the clinic. And fourth is recurrent UTI, which I have said that many asymptomatic patients not presented with pain or hematuria may present with recurrent urinary tract infection. So these are the conditions when it comes to you, always try to find out whether he is having urinary stone disease associated with it or not. These I have already said, that acute ureteric colic, how it happens, why it happens. Next is obstructive uropathy. How the obstructive uropathy takes place? Because the stone can obstruct silently the system. Stone can obstruct silently the system and produces dilatation and increased pressure inside the urinary system, leading to loss of parenchyma. That leads to obstructive uropathy. Patient's urea creatinine may increase by number of folds and patient may even come as a patient of renal failure to you. So even a patient with renal failure comes to you, especially in the younger age. Because what is the importance of renal failure with stone disease? Stone disease is a disease of the younger age group. It usually present between 20 to 50. 20 to 50 is the age group in which the urinary stone disease usually takes place. So a patient of 20 to 50, if they come with renal failure, with raised urea creatinine, you will also have to, apart from blood pressure, diabetes, you will also have to rule out whether patient is having any obstruction, and obstruction is due to stone disease or not. Obstruction is due to stone disease or not, that you will have to rule out. And last but most important relation is the urosepsis. Urosepsis can take place following obstruction. If there is obstruction, the upper part may get dilated and they get infected, because anyway, wherever you keep a portion of the confined water, even in a glass, you will see after 15 days there is accumulation of some organisms in it. Similarly, in an obstructed system, always remember there is accumulation of bacteria and patient may go even into urosepsis. So these are the clinical manifestation which takes place mainly in obstructed renal stone and the ureteric stone. But if you come to the bladder stone, which is not very common in relation to kidney or ureteric stone and can occur in two ways. One is the expulsion from the ureter. From the ureter, the stone has migrated to the urinary bladder, or it has developed de novo in the bladder following lower tract obstruction. Patient is having large prostate, by which there is always some residual urine in the bladder. That retained urine gradually precipitates stone, or if there is recurrent infection in the system, all this leads to the bladder stone formation, or it can come from above. Patient with lower tract obstruction should also be screened for urinary stone disease. We commonly see that there is obstruction, patient has come with narrow flow or difficulty in voiding. On evaluation we find there is a bladder stone in it. So any lower tract symptoms, especially in younger age group or very old population, we must screen for urinary bladder stone. They usually come with suprapubic pain, urinary tract infection, hematuria, dysuria frequency. Are you acquainted with these terms? Hematuria, dysuria and frequency, you know? What is dysuria? Any of you? What is dysuria? Yes, yes, say. Yes, yes. Say, why are you murmuring? Say straightforward what is dysuria, what is hematuria, and what is frequency. Any idea what is frequency? Increased number of urination. So what is the number of urination normally in a person? If he consumes around 2 liters to 2.5 liters, he is not in a very hot climate, he should void 3 to 4 hours a day. Every 3 to 4 hours he should void. If it increases, it is called increased frequency, and if it increases at night, it is called nocturia. Nocturia is a different class, is a different pathology. So these are the increased frequency. Because why there is increased frequency in bladder stone? Because it irritates the trigone. It irritates the trigone and the patient gets the urge for urination. It irritates the mucosa. There is sloughing of the mucosa. There is hematuria. And there is dysuria because there is associated urinary infection because of the stone. And the basic cause of urinary infection, that is why the stone has formed. So these are the reason why there is these 3 symptoms. I am telling you these 3 symptoms so much because these are the most common symptoms where you have to look for any associated pathology in the tract. And fourth is retention of urine. This occurs mostly in association with other lower tract pathologies there, either increased large prostate or urethral stricture, and it is mainly not a very big stone, small stone which enters into the prostatic fossa and produce total urinary tract obstruction. Then how do you diagnose? I am not going into the clinical only the apart from clinical you will have to substantiate the patient is having urinary stone disease. How do you do that? Most important thing, don't forget to do a urine routine examination at least. Culture result you may get later on, but don't forget to do a urine routine examination because you will get lot of information out of it, like you will get presence of crystals, you may get presence of blood in the routine examination. Next is the ultrasound. Provided ultrasound is available and relatively inexpensive and can be done quickly. Third is, I am telling you why, the X-ray QB. The advantage of ultrasound is that it is very quickly done, it is least expensive, and doing without any preparation we can do the investigation and we can diagnose the situation, but it is the operator dependent investigation. You may diagnose it, he may not be able to diagnose it. So there lies the discrepancy why ultrasound is no more the number one choice for the diagnosis of especially the acute condition. If a patient comes to you and if you suspect it is the urinary stone disorder. X-ray QB. X-ray QB, I am giving X-ray, how it comes to you that patient is having a stone like this. Patient is having a stone like this. But what is the disadvantage? Disadvantage, it needs gut preparation. If a patient comes to you in acute pain, will you ask him to go for a gut preparation and get it done? So it is not done nowadays as the number one choice. Yes, in a small setup, in a rural setup where all the time other investigations are not available, that case we should go for a X-ray QB as the primary investigation. But today's investigation of choice is non-contrast CT scan of urinary system. Non-contrast CT scan is 95.5% sensitive in detecting the urinary stone disease, even it is in the dimension of 3 to 4 millimeter. Even if it is in the dimension of 3 to 4 millimeter. IVP is no more done nowadays, but this is the conventional investigation done for urinary stone treatment. I'll tell you why it is done, but normally in the acute phase, IVP is not done. First, in acute phase, the investigation is the urinary investigation, urine routine culture. Gate 1 NCCT QOB that does not require any gut preparation. At the same time, there is no hematological or biochemical investigation is necessary for it. NCCT QOB is the diagnostic choice for acute suspected urinary stone disorder. So this is the CT picture. NCCT QOB, how it looks like. This is the NCCT QOB. সোমা আমি এখানেই ক্লাস নিচ্ছি ক্লাস শেষ করে কন্টাক্ট করব So you see that how it looks in the NCCT QOB, that properly we can diagnose exactly where it is. And have you noticed this? There is one more shadow here. It's a very small shadow. It's hardly 2 to 3 millimeter stone. That has also been picked up in the system. So these are the importance of the NCCT QOB. That is why it is the number of investigation in the presence of Now, if I ask you, if a patient come to you, how will you approach the patient? How will you approach the patient? First of all, take the history. What is the nature of the pain? Also, look at his nature of food habit. Also, take history of his water consumption. Also, take history whether this is the first time former or recurrent stone disease you are having. Or you will have to go for a clinical examination. What is the nature of the symptoms he is presenting with? After that, you will have to advise some investigation which I have made. So if you suspect it is a stone disease and patient came with the acute presentation, ask for urine. I am repeating it because you must remember. Ask for urine, ask for NCCT QOB, ask for X-ray QOB if he has passed his bowel in the morning. Okay. Now, in short, you will have to decide how will you treat the patient. Treat first, if it is acute condition, you will have to treat the patient with adequate analgesic, with hydration, and you will have to get the investigations done. You will have to see that whether this patient is responding to your treatment or not. If the patient responds, you can prepare the patient, follow up the patient, and plan your surgery. But the patient do not respond to your treatment, or the patient is having single kidney. Patient is having single kidney. Patient is having chronic renal disease. Patient is having chronic renal disease. Patient is having evidence of the urosepsis. Chronic renal disease, urosepsis, single renal kidney, and patient not responding to any conservative management of IV, painkiller, analgesic, not responding, you will have to think of immediate relief of symptoms and protection of the system. What are these? Suppose if patient is not responding, You will have to treat the patient with some kind of relief of obstruction. Most commonly it is done if it is the ureteric stone with double J stenting. I will show you what is double J stenting. We will put a stent which is called double J. Upper end lies in the kidney, lower end lies in the urinary bladder. It bypasses the obstruction in the system, relieve the pain, it relieves the infection and prepared the patient for further surgery later on for retrieval of the stone. But who can be wait for whom where we can wait for the treatment, that is the conservative observation. If the stone size is less than 5 millimeter, if the stone size is less than 5 millimeter, that case and the patient is asymptomatic and there is no obstruction related to the system, these are the group of the patients. Then in that case you can wait for conservative management with adequate hydration, painkiller, OPD follow-up. And it has been seen if the stone size is less than 5 millimeter, 60% of the stone gets expulsed over a period of time. But normally if it is symptomatic, we should not wait more than 2 to 3 weeks. We will have to plan some kind of intervention if the patient is symptomatic. So whom we should go for observation? Stone size is small, stone is not causing obstruction, there is no evidence of urosepsis, there is no other predisposing condition like solitary kidney. Patient is having chronic renal failure. That case we have to be more liberal in our decision making to prevent any kind of complication related to the stone. Next is percutaneous nephrolithotomy. I will show you what is percutaneous if time permits. Percutaneous nephrolithotomy, in which what happens in the stone disease, renal stone disease, we in either prone or supine. The patient is lying like this is supine, patient is lying like this is prone. Either of the position, we make a hole in the kidney, we introduce our camera system inside, we break the stone with the energy source, either it is laser or with a pneumatic lithotripter, we break the stone and take it out. I will show you exactly if time permits. So this is called PCNL, which is the most preferred treatment nowadays for the renal stone management, especially if the stone size is more than 2 centimeter. If the stone size is more than 2 centimeter, then we can, this is our treatment of choice. But most important thing, it has lot of complications related to it. Today, if you are interested, we will do one PCNL today here. So if you have time, you can come and find out in the OT. Anyway, so the most interesting thing which has come in the last 10 years is retrograde renal surgery, that is RIRS. IRS, in which we go the way we put our catheter, we will enter the system and will reach the kidney by a special flexible ureteroscope, and we break the stone with energy sources, mainly holmium laser or thulium fiber laser. We make it into dust and we put a double J stent to allow the stone particles to come out freely, and patient can be discharged in a day. It is such a safe surgery. Only problem, there is little higher incidence of the infection. We have to be very careful about the pre-operative antibiotic assessment. At the same time, the sterilization of the instrument, duration of surgery, all these things are very important to prevent infection. But this is the game changer in the management of the renal stone disease. Third is pyelolithotomy and the nephrolithotomy. These are almost gone into the oblivion, but misfortunately in the examination, in the surgical table, you will be asked this thing only, because most of the general surgeons are of the advances which has made place in the urology. So they will ask the nephrolithotomy, pyelolithotomy, these are the conventional surgery which has been almost abundant in the Western world. Only less than 1% of the renal stone disease patient require this kind of surgery. Otherwise, most of the patients can be treated by endourology. And the last you should know, there is one option, that is ESWL, that is extracorporeal shockwave lithotripsy, in which the energy generated outside the body focused with the help of an ellipsoid reflector to the stone with the help of ultrasound or X-ray. With the help of ultrasound or X-ray, we localize the stone beam, the energy beam to the stone, and we break the stone from outside. At one time in the early 2000, this was the most popular method of treating the stone disease. Now also it is available in many parts of the country, and many international bodies are also following this. The indication is less than 1.5 centimeter of the stone. We cannot treat very large stone with it. Less than 1.5 centimeter of the stone, and the hardness of the stone can be done, assessed by a Hounsfield unit in CT scan. Why CT scan is so important? It is not only diagnose, it also helps us to know how hard is the stone, and to treatment decision depends partly on the hardness of the stone also. Okay, so what is important? You will have to know the Hounsfield unit of the stone. There is no obstruction because the stone particles will come down, and also the size of the stone. Size of the stone, Hounsfield unit, and no obstruction in the system. At times the clearance rate is around 65 to 70% with ESWL, and patient may require number of sittings to break the stone into pieces. Now I will show you very briefly what is PCNL. This is, you see, we have made a puncture inside the system. If time permits, through YouTube only, I can show you the videos also, but I don't know time permits or not. We can go into the renal pelvis and we break the stone. This is called amplious sheath, through which we have put our scope and we break the stone with the help of energy. This is called percutaneous nephrolithotomy. Next, I have told you, that is RIRS, that is retrograde intrarenal surgery. You see how we have gone from below, from the urinary tract, we have entered inside the system, and with the help of the energy source like holmium laser or thulium laser, we break the stone into small pieces, and it comes out from the normal urinary passage. This is what is called ESWL. You see that with the help of the X-ray, that is called IITV, with that we localize the stone, and the energy is developed from outside like this, that with a reflector, there is basically a reflector at the base of it. All the waves are made towards the reflector and they gradually converge to the stone. This is a technology created by the Dornier company. You know how it has been done. One scientist was traveling by air. One bird hit the aircraft. What happens? There is no trauma to the intervening substance. Only one glass which was kept at the inside upper layer, that got broken. So he got the idea of breaking a substance at a depth, much inside depth, without causing any trauma to the intervening system. That is why the concept of ESWL come in the early 80s, and gradually it take lot of improvement, and it has become a very small instrument like this by which we can treat this stone. And fortunately, I am telling you, myself undergone this treatment twice in my student life. So this was a very effective treatment protocol, but the clearance rate is 60 to 70%, not more than that. These are those who have spoken about the renal stone, and for ureteric stone is the medical expulsion therapy. I have already said who are the candidate for the medical expulsion therapy. There is no obstruction below. The stone size is less than 5 millimeter. There is no evidence of infection, and the patient can be managed by oral antispasmodic, anti-painkiller, and we can expect the patient to come down. But contraindication, I am telling you repeatedly, I am telling you solitary kidney, patient with renal failure, and another group of patient which needs special attention, that is pregnancy. In pregnancy, you must be very careful how do you treat it. If you want to treat a patient of renal ureteric stone in pregnancy, you can treat only in the second trimester, not in the first, not in the third. Third is due to the anatomical tortuosity of the system. First is there is chance of expulsion of the fetus. So second trimester is the time where you can intervene, otherwise you will have to manage the patient conservatively. Here the medical expulsion therapy, ureteroscopic removal and ureteral lithotomy. I am showing you what is what. You see the stone is in the mid ureter. From the ureteroscope we remove the stone, or we can do it by open pyelolithotomy. Nowadays open pyelolithotomy is not done. Laparoscopic pyelolithotomy, we dissect the ureter and take out the stone. These are the just simple photograph I have kept for your basic understanding that this is how we treat the ureteric stone. We reach the ureter, we break it with laser and take out the stone. And if the stone size is very big, more than 2 centimeter in the ureter, we'll have to go either for some kind of ureteral lithotomy. Either it is open ureteral lithotomy or it is a laparoscopic ureteral lithotomy. This is the bladder stone. Bladder stone, if it is big, it can be removed per urethra with the help of breaking the stone into pieces. You see how we entered the bladder. We see the stone there. We break it with energy source and take it out. That is called cystolithotripsy. Or if the stone is very big, suppose it is 7 centimeter stone, how can you, and it is very common with neurogenic bladder, where there is always retention of urine. Patient is not aware of the sensation of the bladder. If you keep the bladder stone for a longer time, what happens? There is squamous metaplasia of the bladder leading to squamous cell carcinoma, which is the most dreaded complication and the most dreaded urinary tract cancer. That is why bladder stone, if it is of larger dimension, it should be removed. And these are the two methods by which we can remove. I don't know whether you need this because the time is less, but just keep it in mind that metabolic workup is necessary for the recurrent stone former. At the beginning, I have said 30% of the patient get their stone recurred in their lifetime of 7 to 9 years. So those who are recurrent stone former will have to find out whether patient is having any metabolic disorder, out of which clinical examination, dedicated history, imaging of the urinary tract and the biochemical test. The details, I think it is not necessary for you in the undergraduate level, but you should know that these are the things should be done to find out or prevent further development of the stone in the recurrent stone former. How do you treat, what are the therapy recommended for the metabolically positive patient? As I have said, by metabolic evaluation, if we find out any cause for the creation of the stone, we'll have the causes are mainly hypercalciuria, that is more expulsion of the calcium in the urine. Next is hyperoxaluria, that is more expulsion of the oxalate in the urine. Hypocitric aciduria, as I have told you, the citrate. Citrate is so very important. Whether there is deficit in the citrate, then uricosuriya, more uric acid in the system, in the urinary system because of gout. And fifth is the cystinuria, which is the metabolic disorder. These are the metabolic disorder which can find out among this patient, and we will have to treat the patient accordingly. This you need not know, just get the brief idea that these are the patients, recurrent stone formers require special evaluation and they should be treated if we can find out any cause accordingly to prevent or reduce the incidence of the stone formation. And that's all. That's the thank you for you have listened to it. I don't know how much you have taken. Anyway, if you are interested, still 7 minutes left. If you are interested, I will ask her to show one video which may be necessary for you. তুমি একটু পাইলোলিথোটমিটা দেখিয়ে দাও. It is from YouTube only. You can always see at your leisure time. But I am giving you the idea to watch it because it is self-explanatory how it is done. চলবে না? ওই যে ওরা জানে সাদাটা কি করতে বলছে করো। হ্যাঁ। So these are the instruments. See, it is in the flank position. It is in the flank position. We make an incision in the skin and the subcutaneous tissue. You see it later on in your video. We are cutting external oblique, internal oblique, at the back, serratus posterior inferior. These are the things they will ask you in the operative surgery. Those who will be surgeon, this may be the primary surgery you will have to do for renal stone disease. Read, see what is, it's a very good video, that's why I am showing you. Transversus abdominis is, we split the transversus abdominis. You remember, these are the steps of the surgery. We cut external oblique, internal oblique, we split the transversus abdominis, dorsolumbar fascia, and we reach the retroperitoneum. We reach retroperitoneum. See, the fat which is popping out is the retroperitoneal fat. This is the indicator that you are in the right place. They are cutting the gyrotous fascia to open the kidney's structure. If you have time, if you are interested, I can show you the RIRS also, if you are interested. Or you can see it yourself, what is RIRS. This I am showing you because this may be asked in the examination. This is the kidney. You understand, what he is pulling is the kidney. He is cutting the fat inside the gyrotous fascia. He has dissected out the renal pelvis. Can you make out a glistening structure? There is a glistening structure. This is the glistening structure. He is making a stab incision in the renal pelvis. He is opening up the renal pelvis. what he is using is the pyelolithotomy forceps. He has taken out the stone. Understand? This is the pyelolithotomy. You can stop it now. Now they will close it. This is the basic understanding what is called pyelolithotomy.